what I want us to sort of pivot into now is, okay, so we understand that maybe the way we've been thinking about addiction, maybe we've been getting it a little bit wrong, and we're starting to understand more, but we really want to change the way that we do things. We want to change policies, we want to change our funding streams, et cetera. That's where we're going to shift into trauma-informed care. How do we treat people? So let's spend a little bit of time doing this. Trauma-informed care, it's a strengths-based framework that is grounded in an understanding of and responsiveness to the impact of trauma, that emphasizes physical, psychological, and emotional safety, which seems kind of important given what we know about the amygdala, right? For both providers and survivors, and that creates opportunities for survivors to rebuild a sense of control and empowerment. Remember when I talked about trauma and I said that one of the defining features that allows something to either be a traumatic event or not a traumatic event is about control? So key elements of trauma-informed care are promoting safety, specifically because of what we know about the amygdala, and promoting control, specifically because control is one of the things that means things are going to be either traumatic or not traumatic. And in trauma-informed care, one of the key things that I always want to highlight is that we're focusing on the experience that people have in care, or in school, or in the courtroom. We're focusing on the experience people have, not just the outcomes, though the experience will surely influence the outcomes. But so often people come into treatment, and I'm not against tracking treatment outcomes. Of course we should track treatment outcomes. Is what we're doing working? But we don't just want to look at like how many people had a positive graduation. We want to look at how people felt about it when they were moving through our system and engaging with our services. And part of why I think that that's so dang important is because of what we just talked about around recurrence. Recurrence is a normal part of this illness. What we want to do is create systems that invite people back with a lot of love versus stigmatizing their recurrence. Or saying like, we can't support you, you need a higher level of care because of this recurrence. Those kinds of things can be damaging. So in terms of trauma-informed care, we're just going to spend a second talking about language. I want to clarify trauma-informed versus trauma-specific, and we're going to talk about some SAMHSA principles and some other core tenets of trauma-informed care. So let's start with language. Can you guys, I'm realizing right now that you guys probably can't see this at all. Not even a little bit. Okay. So I'm going to explain to you what is on this slide. The slide has, and you'll get this will be emailed to you. It's got words over here on the left that are associated with treatment and recovery, and then it's got either stop signs or green check marks, and then across the top, so what is that, your y-axis? It's got places where it's appropriate to use terms or not. So locations and then terms. And this is based on some of the research by a researcher on the East Coast. His name is Robert Ashford. Of course, he's working in tandem with other people, but I want to highlight who the researcher is here because this is a person in long-term recovery doing the research. And every time that we can choose to highlight the voices of people with lived experience, we want to do that. So if you've got two speakers that could speak on the same thing and one of them has lived experience, pick the person with lived experience. We always want to elevate peers. So Robert is in recovery himself, and this particular, he's done a bunch of research around language and stigma, and this particular research is looking at words that create stigma or words that promote recovery. So the way that the research is done is that people hear the same two stories, but they trade out words and then they ask about the person in the story. So for example, they would say something like, Bob went to the grocery store on Sunday morning. On Sunday afternoon, he experienced a recurrence of use, and on Monday morning, he went to the doctor for life-saving medication. Same story, different words. Bob went to the grocery store on Sunday morning. On Sunday afternoon, he had a relapse, and the following morning, he went to the doctor seeking medication. Same story, right? Told you guys the same story, but I switched out a couple words. So they would tell people, same story, but switch out words, and then ask what people thought about Bob. And what they discovered is that over and over again, some words decreased stigma, and some words increased stigma. And we've already started talking today about how important stigma is around substance use disorders and how stigma influences treatment, policy, funding, etc. And so one of the most sort of core elements of trauma-informed care is really drilling in on the evidence around what words promote recovery and what words promote stigma. So there's actually some fascinating stuff in here. And it's interesting because we talk about language in the substance use disorder world a lot, but it wasn't until recently that I realized how much actual data there was, like real research. So this is not like one person thought that this thing sounded better and more empowering. This is, no, there's real hard data that this word causes harm versus this word promotes recovery and decreases stigma. So the first word on here is addict. The only place that's ever appropriate to say is mutual aid meetings. I purposefully used it today in our initial stories about addiction because I wanted you guys to dance with the underbelly, although none of you did. None of you are allowed back to other trainings of mine because you can't follow instructions. Just kidding. So I purposefully used it, but it's not a word we ever want to use. We never want to say addict. Unless you're in a mutual aid meeting, which means recovery dharma or 12 steps. We just don't use it unless we are someone with lived experience talking to someone else with lived experience. We never say alcoholic, unless, again, we're in a mutual aid meeting. Substance abuser, completely off the table. And why is it so important not to engage with the term abuse when we talk about substance use? Why is that particularly important? Well, it's shaming, yeah. And it's shaming because who are abusers? When you think of people that abuse, who are they? They're bad people. They're usually people that engage in child abuse, pet abuse, spousal abuse. And we actually don't want to stigmatize those people or that behavior either, because shame never changes behavior. But we definitely don't want to conflate people that use substances with violence, right? So we never say substance use, and we never say substance abuser. That's a really tricky one because substance abuse is in every single large organization's name, like SAMHSA. So it's hard. We're stuck with it a little bit, but we don't want to engage with it. We don't want to use it. Relapse. Never okay to say unless you're in a mutual aid meeting. The evidence is really clear that relapse promotes stigma and that the preferred term is recurrence of use. Medication-assisted treatment. Stop signs across the board. The preferred term is medication-supported recovery, medication-assisted recovery. It's the focus on recovery, or my preferred term is just saying pharmacotherapies for addiction. And the American Society of Addiction Medicine has also asked us to change the language, but MAT is in so many policies, laws, it's everywhere. So what ASAM has asked us to do is to assume that MAT, no longer means medication-assisted treatment. MAT means medications for addiction treatment. So they've asked us to replace that because it's so embedded in our language, kind of the same way abuse is. Yeah.
Are they rethinking the term addiction?
I don't know. That's a good question. I don't know. Yeah, they haven't put anything out about that, whereas they've been very clear about MAT, meaning medications for addiction treatment, which I think is a great way to talk about it. And then things that we move into then terms that we want to be using: medication-assisted recovery, person with a substance use disorder, so using person first language, person with an alcohol use disorder, long-term recovery, and pharmacotherapies. And then the one that's not on there, but that I mentioned, was replacing relapse with recurrence of use. So the gold standard that we should be using in this room as professionals and peers, et cetera, is recurrence of use. The one that's not on here that I always want to highlight, but I honestly don't know about evidence behind it, but getting away from the term clean, so saying this person had a clean UA, Because, and again, I don't have evidence behind this, but what's the opposite of clean? No human is dirty, right? I mean, maybe my kid is after she's been playing in the dirt for 5 hours, which she does regularly. But my clients, I don't need to refer to them as dirty humans, right? Which means we also don't want to refer to people as clean humans, because the inverse then becomes also true. All right, so you'll hear me use the terms recurrence of use. You'll hear me talk about urine drug screens that indicate use of a substance versus a dirty UA, and you'll hear some of that stuff sort of interspersed throughout here. So let's talk about what trauma-informed care is versus what trauma-specific care is. Trauma-specific care is when we are addressing a singular pathology, usually with a single person. So there was questions earlier like, hey, does the hippocampus regrow? Can you regrow that? And engaging in regrowing the hippocampus via psychotherapy, let's say, or via taking the medicine lithium, that's a trauma-specific intervention, because you're working with one individual to address a specific pathology, which is really quite different than trauma-informed care. So I always identify, I don't actually think I ever call myself an expert, but if someone said, are you an expert in trauma-specific care? I would say absolutely not. I don't do EMDR. I know pharmacotherapies for PTSD, but I don't really know how to treat PTSD. But if someone said, hey, are you an expert in thinking about how to change systems to be more safe and to offering more control for our clients? I don't know if I'd say I was an expert, but I say, yeah, I've been thinking about that for a long time. So it's a different skill set and it's a different way of thinking about things. Trauma-informed care assumes universal precautions, whereas trauma-specific care, again, is for one person addressing an individual pathology. Trauma-informed care says that we set up entire systems to assume that everyone's experienced trauma. We're just gonna assume you've experienced trauma, and we're gonna build that into the way that we treat you. Or we're gonna build that in because we're gonna put plants in the waiting room, and we know that plants clean the air, whatever it is. We know plants are beautiful and make you feel at home, so we're gonna do that. Trauma-informed care builds trauma-attentive systems for clients and staff, so not just the clients, we're also gonna build systems that acknowledge staff trauma and staff burnout. And trauma-informed care, I think at its core, specifically for substance use disorders, asks us to change how we think about things. And when I say how we think about things, I'm specifically thinking about the causes. So I had you guys dive into what causes addiction, because I think if we start thinking about, again, why does this stuff happen? It's gonna transform the way that we treat people. So if someone shows up and they have a urine drug screen that indicates the presence of an illicit substance, and I think that trauma and stress was the cause of their recent recurrence of use, I'm gonna respond to them really differently than if I think their poor morals caused a relapse, right? So that's what trauma-informed care is. It's a different way of understanding and a different way of building systems to be attentive to people's experience. Any questions about trauma-informed versus trauma-specific? I'm always amazed at how common it is to get this confused and how easy it is to sort of entangle them. Like, for example, people always want to screen for trauma to be more trauma-informed. But guess what's really traumatizing? Being asked about your trauma history without any safe container that you can later close up. So it's always like, people will ask me to come consult about how to become more trauma-informed, and they'll be so excited. They're like, and we started doing ACEs at intake? And I'm like, oh no. And it's kind of useful to know what your average ACEs score for your clients, but is that really gonna change the way you build a system? Probably not. Did you have a question?
Sort of. I've been struggling with this a bit in our clinic, just in that I think there's some discrepancy just in the thought process of some individuals as it relates to trauma-informed care and trauma-specific care. So someone who's scheduling for a new patient appointment, there's this drive to know all there is to know about the person before they come in, so that you can be very specific in your care. But my concern is that you're reading a person's history through another person's lens, and that's influencing, to whatever degree, the care that they get once they arrive. And just interested on your viewpoint of whether, I mean, it seems totally logical to let a person tell their own story and to reveal what they're ready to reveal, as opposed to trying to get a snapshot of the person before they even arrive.
Yeah, so let me see if I can answer the question. Tell me if I'm not getting to the heart of it. We do not need to know someone's trauma history to provide them care. The person that needs to know someone's trauma history is a PTSD or trauma-specific therapist. I even prescribe medicines for people and give them diagnoses of PTSD, and I specifically tell them that I don't need to know what the flashbacks are about or what the nightmares are about. You don't need to know that to provide amazing care to people. Asking about that should be done when there's an incredibly safe container and you really have the skills to open it and close it. People will share that stuff. They will, and that's okay. You don't have to shut them down, but you don't need to know that stuff. You don't need to address that in the initial substance use disorder assessment. You don't need to address that in the initial mental health assessment. What you do need to address is the symptoms and how that changes someone's functionality. And people will tell you when they're ready to tell you, and usually it's faster than we actually need to know. Does that answer the question? Okay, great, good. Yes, we don't need to do trauma screenings. That's why we build universal precautions into, am I causing that? That's why we build universal precautions into our systems. Because we're just gonna assume. We're just gonna assume that you've experienced trauma. If we go back to thinking about that number, think how many times, what's the likelihood? What's the number? 46 times or 4,600 times more likely. So if we work in substance use disorder services, or we write substance use disorder policy, or we determine funding for substance use disorders, we're just gonna assume, because we know that number, that every single person that we touch has experienced trauma. Boom, we're done. We don't need to do fancy assessments. That's it, that's all we need to know. Okay, so let's talk about SAMHSA's key principles here. Safety. That's actually a great sort of jump off. So SAMHSA says that to be a trauma-informed system, you have to promote safety. One thing that we do in substance use disorder services is we ask people often on the first visit to review their trauma history with us. So if we're thinking about things from a trauma-informed lens and how to promote safety, we might do that a little bit differently. The other thing I think about a lot in the context of medication-supported recovery or pharmacotherapies for addiction is that sometimes people have sort of chaotic medication-supported recovery services that don't always have access to refills of medications. If withdrawals literally feel traumatic, wouldn't you then create a system where people almost never run out of medication? That's like just built into how you have the system. They don't run out of medication because you don't want someone in withdrawals. So safety is a core element, and that shows up in a variety of different ways, and we'll come back to it in case studies. But whenever you need to make a decision and think about safety, you're gonna prioritize what makes the client feel the safest. And sometimes people ask me, well, this is a good example. We had Central City Concern hired some outside consultants to help us with some work. And so these like consultant project manager types came, and we kept talking about trauma-informed care. And the woman said, well, yeah, but what is trauma-informed care? Like, explain it to me. And I have like a minute basically to explain it to her. And I was like, well, here's what trauma-informed care is. Here, trauma-informed care means that you're going to set up an office to serve a client in, and you need a place for a therapist or a service provider to sit, and you need a place for a client to sit. In historical paradigms, we would have prioritized that the provider or the clinician could get out of the room as fast as possible to be safe from the client. In trauma-informed care, we go, okay, what do we know about the neurobiology of trauma? And we're gonna prioritize safety. And so we're gonna put both the clinician and the client equidistance from the door. So that's like the key of trauma-informed care is what thing makes us, and then we ask the question, where does the chair go that makes the client feel safest? Boom, that's what trauma-informed care is. So then the next one is trustworthiness and transparency. So constantly asking ourselves, is this decision we're making, is this based on trustworthiness and transparency? So for example, if we're gonna do a recovery action plan with someone or quote unquote put them on a contract, is the contract fully transparent? Do they know exactly what's gonna happen if the contract doesn't go well? Have we built a service or a system that's completely trustworthy, where clients trust that we're gonna do what we said that we were gonna do? Trauma-informed systems also rely very heavily on peers. I'm someone in long-term recovery from substances, but my role in a treatment team is very different from that of a peer. A peer is there with the primary responsibility of bringing the voice of lived experience of substance use. The peer is the translator between the person in services and the people offering services, and is usually really the expert in the room about what people's lives are like and the ability to just initially make that connection. I sometimes think that a really, really good treatment service is primarily peers, because peers help people walk through and into a new way of doing things, usually at their own pace. My favorite peer story, actually, gosh, I have so many favorite peer stories, but one of my favorite peer stories was when I was early in working in medication-supported recovery, and it was like 5:02 on a Friday, and a client called and needed a refill on their buprenorphine prescription. And I was like, whatever, it's after 5, they're just gonna have to deal with it. This is called natural consequences, and they need to learn how to manage their time. And the peer looked at me and he was like, Lydia, have you ever been in opioid withdrawals before? Tell me what it's like. And I couldn't tell him. And he was like, well, what do you think would be different if you had? I was like, oh, I'd probably give him a script for the weekend and I'd have him come in first thing Monday morning so that we could do some collaborative problem solving. Oh, yep, you're right, that's the right decision to make. We give people life-saving medication even if they're struggling with time management. And I learned that from watching a peer. The other thing that I learned from working really closely with peers was how shameful it was to ask for refills. So one of the peers that I've worked with for a long time talked to me a lot. We did a presentation together about a year ago, and so I kind of sat with her and we did some sort of like interviews around like, what's it like to work with a medical provider when you're active in your addiction? And the thing that she said over and over again was like how scary it was to see a medical provider because they were gonna shame you, specifically if you needed basically any kind of medicine at all. So she lost her meds once when she was in a medication-supported recovery treatment program, and she was horrified to tell people she'd lost 2 days of meds because she thought that she'd be stigmatized, treated like a criminal, etc. And she said that it was the most welcome thing ever when the clinician said, no worries, I got you. You might have to pay out of pocket because insurance isn't gonna cover this, but it's your first time, so I'm not super worried about it. She said that that was the moment she thought she could trust a medical provider, was when they didn't judge her for asking for a medicine. And I don't think I ever really would have thought about that, except for talking to peers that had really been through the system and known what it was like to feel so ashamed and scared to ask to have your basic needs met. So peers, totally central. The other thing that's central is collaboration and mutuality. This goes back to giving people their power back. So whenever you can collaborate and be more mutual with clients, you want to centralize it. I always understand the meaning behind the statement, but I still find it so funny when people are like, oh yeah, that guy in treatment, that guy, he's working his own program. He's doing his own program, which is like derogatory, right? Like this person's not really doing what I'm wanting them to do. And in my head, whenever people say that, I'm like, dude, shouldn't he be? Like, shouldn't it be their own program? Shouldn't they have come in and outlined with you exactly what treatment was gonna look like and how they would know if they were being successful versus not? Yeah, people should be working their own program. It's kind of what we want them to do. In tandem with that is empowerment, voice, and choice, so giving people as many choices as possible to allow for control. And then I'm not crazy about the way SAMHSA says this, but they call it cultural, historical, and gender issues, which I take to mean that, again, when we talk about trauma, we're not just talking about individual experiences, we're talking about much larger structural violence concerns, and that we want to be thinking about that whenever we provide treatment. So we want to be like looking at it through that lens whenever we're offering treatment. So maybe that means that we have more treatment providers that look like the people that we're serving. Maybe that means we have more treatment providers that speak the same language as the people we're serving. So we always want to be thinking about trauma not just as an individual thing, but as something that groups of people experience as well. And then a couple things that I just wanted to add in here today. I talk a lot about just care, and I've come to realize that no one ever knows what I'm talking about when I say this. So when I'm talking about just care, what I mean is that we treat everyone the same as much as possible, and we build systems that treat everyone the same as much as possible, regardless of their ability to either self-advocate or be kind and fun to work with. So here's an example of this. When I started working at one particular treatment center, the peers would take their cell phones home, and they would sometimes respond to text messages after work. And there's something so like lovely and like homey feeling about that, right? Like the peer just like, oh yeah, they're around to support. But what does that inherently set up? It sets up that there's going to be times that the peer answers their phone, and there's going to be times when they don't answer their phone after hours. What is going to determine those times that the peer answers their phone versus doesn't? You don't have to answer it, just think about it for a second. One is whether they're busy, like maybe they're with their kid, they can't answer the phone. But the other is like, how much does the person calling bug them? Is that the person that you love to work with and you feel like, oh, we're just really getting a lot done and they're so compliant? And then there's the person that really, really bugs you and you don't answer the phone because they bug you and you don't want to pick up at 9 and they're probably in crisis yet again and they're really hard when they're in crisis. So you always want to build systems where regardless of how good someone is at self-advocating or how likable they are, they have the same access to all the same things. Because guess what trauma makes people? Sometimes not that likable or fun to work with. That's just the truth of it. It's really easy for me to get up here and talk about trauma from care and blah, blah, blah. And then when you get into the office with someone that's experienced a ton of trauma, you're like, oh my God, you're horrible, right? You don't want to be around them. So we never want to set up systems that encourage that encourage people not treating the same. If we make treatment decisions to individualize, it's because of people's vulnerability. So when we decide that this person is going to get into housing instead of this person, it's not because this person's doing better in recovery, it's not because you like working with them more. We make that decision based on how vulnerable the two individuals are. And the person that's more vulnerable gets the place in housing. So just care means you don't set up systems that are nicer to people that are easier to work with, and instead says, no, we make individualized decisions because some people are more vulnerable than others. Does that make sense? Okay. We do try to individualize care when possible, especially related to vulnerability. So we try not to create treatment systems that are like check boxes. So you have to do this, and then you have to do this, and then you have to do this, and you have to do this, and then you've graduated. We try to create treatment systems that say, hey you, what is it gonna look like when you graduate? Okay, great, now we're gonna start working on that. What do you need to get there? A good treatment system individualizes care. And then we do a lot of highly rewarding care. So remember what's dopaminergic. From an ancestral perspective, things that are dopaminergic are high caloric food, and then sex and human connection. So it means every time someone walks into the door, no matter what their urine drug screens look like, we give them rewarding interactions. Oh my gosh, it's so good to see you. I'm so glad you're safe. I'm so glad you're here today. It's really a pleasure to have you in the clinic today. Even when they're doing everything that's making you angry. That's the time to lean in to highly rewarding care. So it's really loving care that rewards them just for engaging. We also want to do care with an emphasis on harm reduction. And the reason I call this one out and why I think trauma-informed care and harm reduction sort of have overlap has to do with control. The ultimate in self-determination and controlling your own life is continuing to use substances and having someone tell you that they love you and they'll serve you anyways. That's the ultimate control versus I'm going to serve you when you are at my place of readiness. Now, does that mean that all of our recovery services are just going to start intermingling people that are actively using with people that are not actively using? Probably not. But it does mean that instead of discouraging people that are still actively using from engaging in services even minimally, we want to avoid as much as possible. Because you know what's a lot safer for people that are actively using drugs? To be engaged even minimally versus not engaged at all from our system. We always want to bring people in if we have a way to do that. And along with that, low barrier care. And this kind of goes back to working with the peers. One of the things that one of the peers told me before she got into medication-supported recovery services, she said that there was this vibe for getting into treatment services that she had to want it enough. And she didn't know how to tell people how much she wanted it. So there was this vibe if she went to the withdrawal management center, and the vibe came because you had to show up 3 or 4 mornings in a row, and that would prove that you really wanted it, and then you could get in. Or you had to come to a wait list group, and then you could get in. And she said that it felt like people didn't want her. It felt like they wanted her to struggle as much as she could, and then they would be of service to her. And that when there was the ability to just get in easily, the moment that she made the decision that she wanted things to change, that's what made all the difference for her. So the time that she ended up getting into treatment services is that she happened to show up at Hooper on a day when there wasn't a wait. Because before that, she'd come to Hooper for a day, and they'd tell her to come back the next day, and she felt like they didn't want her. And so she wouldn't show up the next day. She felt like she was being told, like, try harder, basically. So the moment she got engaged, and now she has been free of substances for almost 6 years, and she's an amazing peer recovery mentor, was because she was able to just walk in and go. So we want to make care that feels really inviting. And one of the ways to do that is to make it more low barrier. To say, hey, we want you to be here. It's easy to be here. And sometimes people will say, well, if you make it really easy to get in, those people aren't as successful. And so we really want our services to be really for the people that are going to be successful with this. And I actually get the impetus behind it, but how many times do people, specifically for opiate use disorder, but we could probably generalize this, how many treatment touches do people need usually before their illness goes into remission? 7. So if they come into treatment and they blow out after 2 weeks, that's not a failure in my mind. That means that we had a chance to show that person that they were really loved and that they have a safe place to come back to. And that when they decide to come back, it's gonna be really rewarding, and we're gonna go, oh my gosh, I'm so glad you're back. I'm so glad you're safe. Because then when they have another recurrence of use, they're gonna know that they can come straight back to us and be safer versus not engaged and not as safe. And I think that's it. I think that's it for my review of trauma-informed care.